The next speaker is Dr. Divya Menon. She's a high-volume phaco surgeon working at the Abate Eye Hospital. She's also a close friend of mine.
A warm good morning to all of you. My half of the job is done by Anup. Uh, anyway, the expert at anything was once a beginner. So I'll be dealing with a step-by-step guide to setting up your first phacoemulsification surgery. So I'll be going through prerequisites, case selection, equipment setup, instrument verification, what to expect, and how to tackle the unexpected complications. So the major prerequisite for the first case is knowledge foundation. As Dr. Anup had already said, we have to master the phacoemulsification principles initially. You should know the ocular anatomy and the cataract pathology because each eye is different. Each cataract is different. You can have soft cataract, hard cataracts, leathery cataracts, and all cataracts give a different feel when you go inside the eye. Understand each surgical step and instrument functions thoroughly. Hone the microsurgery techniques through wet labs and simulators. Dr. Sharika will be dealing with it in detail. Focus on your hand-eye coordination and instrument control. Ensure the phaco machine calibration and staff readiness. Familiarize yourself with the OR layout. And as Dr. Anup had already dealt, you must go through many visuals and diagrams. There are umpteen number of good videos on the YouTube by Deepak Megur, Dr. Saurabh Patwardhan, Dr. Uday Devgan. They are excellent videos and they give you very good knowledge about how to go through your first initial surgeries. The main thing which I tell my juniors is about the hand positioning during phaco. You should always hold the phaco probe in your right hand, provided you're a right-handed person. The phaco probe should be in a pencil holding or in a pencil grasp position. Rest your right hand on the patient's cheekbone and left hand on the patient's forehead so that your wrist joint is stabilized and your movement is only at the fingertips. The correct handpiece angle minimizes the endothelial damage. Each movement of your phaco can cause endothelial damage, so you should have a correct angle for that. And always maintain a safe distance from the posterior capsule as well as from the endothelium. You should always have a troubleshooting guideline so that whenever you end up having any trouble, you can have a systematic approach to resolve issues efficiently. Now that you're confident about the phaco surgeries and ocular anatomy and the ocular cataract pathology, don't be in a hurry to go and do your case because it is very important to select your patients. In your initial surgeries, do suitable patients with just moderate cataracts, clear cornea, normal AC depth, intact zonules, well dilated pupil. Avoid complicated cataracts in your initial surgeries, and I would also say avoid apprehensive patients, avoid known patients and VIP patients because they will definitely cause trouble. Patient education is very important. Sit with them, explain the procedures, risk and expected outcomes. Address all the patient concerns to ensure the comfort. Equipment setup is very important. Double check the IOL power and always be ready with a plan B. Be ready with secondary scleral fixated the iris claw lens or 3-piece IOLs so that in case you end up with any PCR, you have a plan B to go about. Adjust the microscope height for optimal visualization. You must know your microscope before you before you start your surgery. You have to orient the oculars in the right position if you are operating from a temporal or a superior approach. Identify the center focus or the XY button and remember to press it at the beginning of the new case so that your microscope is reset before the surgery begins. Check your interpupillary distance and adjust the oculars to 0. In both the objectives should be 0. Practice to move the microscope manually with hands. All of these skills, although seemingly simple, but they are very critical in keeping a smooth case flow. You must know your foot pedals because as Dr. Anup said, it is like driving a car. So all 4 extremities are in job. So you have your, under your left foot, you have your microscope foot pedal and under your right foot, you have a phaco foot pedal. The phaco foot pedal again has 3 positions as you all know. Position 1 is irrigation, Phaco 2, the position 2 is aspiration and position 3 is phaco. You must be thorough with your phaco machine settings and phaco dynamics. There are 4 main things: power, aspiration, vacuum and bottle height. Power is the ultrasound energy which is used to break up the cataract. Aspiration rate is the rate at which the fluid enters the phacoemulsification tip. It controls the speed with which the pieces of lens comes into the phaco tip. Higher aspiration rate can be kept for faster and experienced surgeon, but as a beginner, it is always advisable to go for a low AFR and in scenarios where you have PCRs. Vacuum defines how strongly the nucleus pieces are held by the phaco tip. Higher vacuum settings are often required during the chopping maneuvers in order to establish a strong purchase of the lens nucleus. Many phaco machines rely on bottle height, where the inflow of fluid into the eye is based on the gravity fluidics. So depending upon the cataract and depending upon the eyes, you have to adjust your bottle height. New mid-generation machines now use infusion pumps to maintain a chosen IOP in the eye and for the anterior chamber stability. So these 4 factors are modulated based upon which step of cataract surgery you are performing. You have to take time and sit down with the manufacturer's representative of the platform you'll be using during your training, so that you can customize the phaco power settings or phaco settings to up to your convenience during your initial surgeries. This is very important. So because they will have they must have seen so many cataract surgeons operating, so they will adjust this phaco machine settings up to your convenience. And instrument verification is again very important. Confirm the availability of all the necessary instruments. Ensure the sterility and proper functioning of each instrument. You must be comfortable using all these instruments as well. The usual problem we have is during the dislodging of the IOL. If it is very hard, the IOL just shoots in and you can end up in PC tear. So you must verify all this beforehand. Anticipate longer operating time initially. Focus on precision rather than speed during your learning phase. Be prepared for variations in the lens density, capsular excess. Monitor the intraocular pressure closely throughout the procedure. Expect high success rate with proper preparation. Now, the step-by-step guidance Dr. Anoop has already dealt with, the incision and capsular excess, nucleus assembly and all. You have to deal with the unexpected issues, like if you have a capsular tear, apply cohesive OVDs, reassess and adjust your technique. Poor visualization, adjust the lighting and use pupil expanders. If you have any machine issues, perform quick troubleshooting or seek immediate assistance. Consult experienced colleagues for advice and reassurance. Discuss the potential challenges and strategies beforehand. You have to analyze each case. Before starting your case, sit back and decide in which type or what is the plan of action you're going to do with this patient. See many surgeries before you enter your OT, and you must talk to your senior colleagues or senior mentors if you know that if you anticipate that you're going to face any problems, they can give you guidance accordingly. So preparation is the key. Invest time in thorough preparation. Knowledge and practice build confidence and improve the outcomes. Embrace the journey. View each case as a learning opportunity. Progress comes with experience and reflection. Set goals for each procedure. Strive for refinement in technique and efficiency with every case. Thank you.